In the College of Health and Human Services Conversation Series, my name is Stephen Hooker, and I have the pleasure of serving as Dean for the college. I'd like to take a few minutes to briefly orient you to the School of Nursing, which is the area of the college you'll be hearing from today. First, I would like to acknowledge that for millennia, the Kumeyaay people have been a part of this land. This land has nourished, healed, protected, and embraced them for many generations in a relationship of balance and harmony. As members of the San Diego State community, we acknowledge this legacy. We promote this balance and harmony. We find inspiration from this land, the land of the Kumeyaay. A few housekeeping notes for today. The event is being recorded, as many of you just heard. During the presentation, please keep your microphone muted. We will be holding a Q&A session toward the end of the event. If you have any questions, we encourage you to submit them in the chat box, which we will be monitoring. Okay, about today's speaker is from the School of Nursing, as I mentioned earlier. The School of Nursing is recognized as a leader in undergraduate nursing education, with its high percentage of students from populations underrepresented in nursing. Our graduates are heavily represented within every healthcare system in the region. The school has 2 graduate concentrations, an advanced practice nursing of adults and the elderly concentration, and a nursing leadership in healthcare systems concentration. Through these graduate programs, SDSU prepares the next generation of providers and leaders for the healthcare community. And faculty in the school are clinicians and scholars with a wide range of expertise who collaborate across many disciplines within SDSU and others such as UCSD. Now I'd like to take this opportunity to introduce today's speaker. Dr. Christine Nibelink has her PhD in nursing informatics from the University of Arizona College of Nursing. She completed her postdoctoral fellowship in biomedical informatics at the University of California, San Diego School of Medicine. Her background is in acute care nursing, including telemetry and intensive care units. Her nursing education experience includes medical surgical nursing and high-fidelity human patient simulation. Based on clinical and educational experience, Dr. Nibelink developed research interests focused on decision-making and communication in acute care environments. Previous research includes the influence of high-fidelity human patient simulation on nursing students' self-efficacy, factors influential to acute care nurse decision-making, and factors influential to nurse and physician decision-making during interprofessional communication. Without further ado, please welcome today's speaker, Dr. Christine Nibelink.
Thank you, Dean Hooker, and thank you, Phil and Natasha and Stacy for your support in this. I'm going to go ahead and start my presentation, share my screen. And okay. Are you seeing the presentation? Okay. So the title of my presentation today is What Nurses Do and Why It Matters. As a nurse, I find that oftentimes the members of the public and other professions don't truly understand what the role of nurses is. So part of my goal is to describe what that is and also discuss factors that are relevant to nursing practice in acute care settings. So we're going to start the presentation with a little bit further description of programs at San Diego State and describe what acute care nursing is and some factors influential to nurse decision-making and caring for patients in those acute care settings. I'm going to relate that to a particular disease process, which is COVID, and how decision-making and communication occurs with that particular disease process. We'll talk about how you as a patient can be facilitated in your engagement in your decision-making and the overall goals for your patient care so that your needs are met in the way you would like for them to be met. And then we'll discuss future thoughts for research in nursing. So at San Diego State, we have an undergraduate program that is #1 in the nation in terms of Hispanic serving. So that's quite an accomplishment. It includes programs of community health, psychiatric mental health, and acute care nurses. So providing education for nurses to be available for patient care in a variety of settings. The master's program includes a combined program so that nurses graduating from this are both nurse practitioners and clinical nurse specialists, and also prepares them to be nursing leaders in their environments. So there's a variety of nursing research being conducted at San Diego State, so I'm just going to briefly go over a few of the nurses that are doing research. Dr. Julie Graham is looking at shock and respiratory failure in patients with critical illness. Dr. Judy Dye is looking at quality of life and healthcare access for women veterans and factors contributing to health outcomes in combat injured women. Dr. Amanda Shaflett and Dr. Dye together are looking at COVID, nurse anxiety, coping, and resilience. Dr. Shaflett is also exploring nurse mental health, including suicide, substance use, and job loss. And my focus is on factors influencing acute care nurse decision-making and communication, and that's going to be the focus of this presentation today. So just to start us off so that we're all on the same page, what is acute care? So there's several different definitions, but essentially these are patients that have been sick for a relatively short duration of time. But this would also include patients who have an uptick in their symptoms of chronic illness. So suddenly they've had a chronic illness for quite some time, but now they're a lot more sick and they have to go into the hospital. These acutely ill patients often need time-sensitive responses so that they achieve their ideal patient outcomes. So a little bit on myself and my background and what led me to want to do this. I started off after graduating from my undergraduate as a floor nurse, which is what we refer to when nurses work on nursing units, that it's less acutely ill than the intensive care unit, but still every hospitalized patient is very acutely ill. So floor nurses do take care of very sick patients. After some time in that area, I went on to the intensive care unit. And in both of these circumstances, I found that when I started in these two different areas, I went through this period of time where I felt like there was a gap in my knowledge. Despite the fact I'd had years of education and also went through preceptorships for both of these areas, it took some time for me to develop experience to really help support my decision-making when suddenly a patient would become very ill. And I'll give you an example. When I first became a floor nurse, very young, I was about 21 years old, I started off my night shift and assessed my patient when I initially started my shift. And I had several patients that night. And obviously you want to let patients sleep, but you also have to assess them to make sure that they're doing okay. So it was about 11:30 midnight. And this patient seemed to be very stable. All vital signs were good. The patient was communicating well and everything was going well. A couple hours later, I came back in and the patient was struggling to speak and had an asymmetrical facial expression. So I knew right away this patient was experiencing a stroke. And I remember at that time focusing entirely on the physical symptoms for that patient because I felt like I didn't have the experience necessary to make decisions without really focusing on the physical needs of that patient. And that patient did end up having a good outcome. I assessed him, I called the physician, communicated successfully what was wrong with that patient so that then that physician could make decisions and prescribe interventions that I could carry out for that patient. But when I went home that day, I realized that I missed the piece that was caring. And so we're going to discuss the whole spectrum, but include that caring piece. And with these things, I became a nurse educator, and I found that nurses graduating from nursing programs had similar experiences where they felt like there was a gap. They didn't have that experience to rely on when they were caring for very sick patients. And also, new graduates tend to do what I did and focus on those physical symptoms and struggle with that caring piece because they're working so hard to address the physical issues. So I decided that I really wanted to focus my research on nurse decision-making so those decisions could be supported better, and communication, both with patients and with other members of the healthcare team, which could include physicians, social workers, speech language pathologists, pharmacists, wound care nurses, a wide variety of people that are relevant for that particular patient care experience. So a little bit of background. Obviously, there's a lot of research that's been done on this. The initial study that really got the ball rolling, that made everyone really care about decisions that are made in hospitals, was a study done several years ago by the Institute of Medicine that identified almost 100,000 patients die each year in U.S. hospitals, in part due to errors in communication and decision making. We also know that a lot of patients die from circumstances such as cardiac arrest, that if those symptoms are identified early, that potentially the patient outcomes could be improved. So we want to make sure that we tie those early identification of symptoms with evidence so that we can get those best patient outcomes, because evidence, obviously a lot of research has been done, and tying those interventions with the latest research results is important to have the best patient outcomes. Previously, all the research and decision making was focused on very much what the evidence says to do. And what we find is people with experience don't read the research when a patient is having a time-limited crisis. They tend to reflect on their experience. So the classical decision-making research isn't as helpful as it could be. Nurses make decisions in a very distracting environment. There's a lot going on. So they have multiple patients, all of which are communicating with the nurse, multiple people in the healthcare team for each patient. And there's a lot of assessment information that the nurses are taking in. So how do they tease apart that information to make a good decision? The other piece is nurses are consistently present at that patient's bedside. And so their role and that presence at the bedside is a wonderful resource to better support early identification of these symptoms so that outcomes are improved because you're intervening early. When I started my PhD and I was sharing with people, even people who work in healthcare, what my focus of my research was going to be, this was the question I was asked frequently: what decisions do nurses make? And so I realized that not everybody understands this. So I'm going to discuss it just a little bit here. So nurses assess their patients. As I talked about in my example, the first thing I did at the beginning of my shift was assess my patients, because I want to know their physical symptoms. I want to know their psychosocial needs. I want to understand what their goals are for their health care. I want to be able to advocate for these patients. And we're going to discuss advocacy in a minute, so that I can better support the ideal outcomes that patient wants, make sure that the patient is included in the goals with the healthcare team. Overall, all of this taken together is the nurse. This all supports understanding for the nurse of the patient's status so that they can best take care of that patient. This leads to planning for the patient care process, includes what the nurse plans to do for interventions to achieve these goals. But then the nurse evaluates the patient's response to these interventions, or potentially no intervention is needed because the patient is stable. But then it's followed up by reassessment. So this is an ongoing process that is absolutely essential to effective nursing care of patients. So when discussing advocacy, nurses this is a big part of the nursing role. And this is part of what I think may not necessarily be obvious to patients and family members. Nurses do a lot in their communication with other healthcare team members to support patients' rights to make decisions about their own care, so that the patient's goals are not ignored and are an important piece of what everyone in the healthcare team is taking into consideration when that patient care decisions are being made. Sometimes nurses identify things that patients and families themselves may not understand are essential to achieving this awareness of what the patient's goals are for the healthcare plan and for interventions. And so nurses oftentimes have to, through their assessment and through their conversations with these patients, be able to carry that message forward, so that the rest of the healthcare team is aware and understands what's going on. So a little bit more on nurse decision-making in acute care. It's often time limited and complex. So there's a change in patient status, which, reflecting back on the patient I discussed initially, the patient status changed and I needed to do something right away. And I had a lot of other patients, but I had to focus on that patient. I had to be able to assess effectively, identify what needs that patient had, and ideally an experienced nurse is going to rely on their experience to support their decision making. There are a lot of factors that are taken into consideration over and above just looking at that patient and reflecting on your own experience. There's rules within the organization. Nursing unit cultural factors could include how supported a nurse feels in his or her particular nursing unit, whether or not they feel they can reach out to a more experienced colleague for support. Ideally, they're going to include the latest research findings, but as I said earlier, that's a struggle, particularly in these time-limited circumstances when you're making decisions. And nurses are not making decisions in a vacuum. They have to communicate with healthcare team members. So that means they need to have done an effective assessment that they can then carry on to the healthcare team members so everyone's on the same page and understands what's going on with this patient. This entire process includes a lot of uncertainty because the patients don't read the textbooks, that every patient's response to an illness is different. And so a lot of times that can add to the stress overall. So this is just a quick slide kind of looking at the fact that in addition to everything else that's going on, nurses need to tease apart things that are noise versus things that are not noise and understand whether or not a particular cue is something that they need to ignore, which would be in the white area under noise where it says correct rejection, or it's a cue that is a hit, which is a signal that they do need to intervene appropriately. In the gray areas, sometimes nurses miss something, identify it as noise when it's actually something significant, and that would not lead to an ideal outcome. Or they, on the other side of the midline, have a false alarm. They misidentify a cue as significant and respond to it when they shouldn't. So we want to maximize the white areas and minimize the gray areas. So we've talked a little bit about understanding the patient status. I'm going to go a little bit more into that. As I've said, nurses have this unique ability because physicians are caring for patients all over the hospital, and they're just not able to be in that patient environment all the time. Nurses are. So in this understanding of patient status, this includes that correct perception changes occur within the patient status, and oftentimes these changes are subtle. So being on top of your assessment, being able to connect significant from non-significant changes in patient status is a very important piece and gets the process starting. They comprehend the significance of those changes, that it's something that could potentially be a very bad outcome if it's not addressed right away, and they project into the future what they think will happen and whether or not they need to intervene. As we've said, nursing, as I've said, nursing is often the presence that's responsible for these early identifications. So supporting nursing decision-making, supporting this understanding of patient status, for example, because obviously there's much more to nursing practice, but supporting this is absolutely essential for effective patient outcomes. What are nursing interventions? So a lot of people, that question, what decisions do nurses make, comes from situations when people don't understand that there's more to nursing practice than simply administering medication as prescribed by the physician or just carrying out physician's orders. That is a big part of what nurses do, and understanding whether or not medication should be held because a patient's status has changed significantly, and that nurse needs to then communicate that change with the physician is also something that's important, and physicians rely on nurses for this. They advocate for patients, as we've talked about, making sure the patient's goals and needs are central to the entire decision-making process. Other things that nurses do is they mobilize patients, so they get them up out of bed, sit them in a chair, encourage them to walk, because all of this is part of the cure and getting home successfully and being healthy. Skincare is a big focus of nursing practice. Patients in acute care spend a lot of time in bed and are at high risk for developing pressure ulcers. which have a significant morbidity and mortality for patients. We want to prevent those things, and nurses are constantly assessing skin and addressing skincare in order to prevent this. Communication, as we've talked about, with every member of the healthcare team, with the patients, with the families, and education is a big part of this. So education in terms of what nurses are doing while the patient is in the hospital, education about what the patient and the family need to consider when the patient goes home. Sometimes patients go home with extensive dressing changes, and there's a lot of education around that, or someone who's newly diagnosed with diabetes. Nurses do a lot of this education because ideally we want patients to stay home and not have to come back to the hospital. We want them to be successful at home and be able to participate in their own care. And then planning for discharge. A lot of times patients need equipment at home that they haven't needed in the past. And making sure that everyone on the healthcare team is aware of what the patient's needs are for discharge. This next bullet is an absolutely essential piece of what nurses do, the caring piece. It's very hard to just simply describe it. We're going to have a video in a minute that does a much better job than I could do just sitting here describing it in a PowerPoint slide. But listening, communicating, supporting that patient so that patient knows that they're well cared for in that hospital environment, and that families know that their family member is well cared for is absolutely essential to nursing practice. And of course, there's much more. So currently, well, that IOM study that identified 100,000 people die each year was a big impetus for getting this electronic health record integrated throughout healthcare in the United States. And this was a big lift, and now it is everywhere. And it is a wonderful resource. Nurses use it to upload all their patient data information. So it's got a lot of information in there about patients, and that's wonderful. But what we find is it doesn't do a great job of supporting communication and decision making for nurses. It's not readily accessed by physicians necessarily. The nursing records aren't, and this could be very helpful in terms of helping support physician decision making. In terms of nursing decision support, the level of support is very low. So as a result, nurses are not finding that it's a supportive tool. So they prefer to talk with their colleagues, and they are not using electronic health records to support their decision making. So here's a little schematic, just kind of presenting it in a little kind of summative manner. The half circle at the very top are the factors that nurses bring with them to patient care situations. And of course, there are others, but these include organizational influences, nursing unit culture influences, their personal experience, the way they collaborate with their colleagues. Oftentimes, nurses, as I've said, find the colleague collaboration to be the most important decision support in their environment. They then approach their patient care, starting off with assessing their patient on all the different levels we've discussed already, so they achieve that understanding of patient status, which drives their decision-making process. They go on to recognize a patient's situation as similar to their previous experience if they have that experience, or sometimes they do recognize that they've read something in the research that what the patient is exhibiting it's similar to that research study. Maybe their education, they reflect on their own education. And this piece is called pattern matching. Then the nurse goes on to consider different interventions based on their experience, and decisions are made based on this analysis. They then communicate with physicians. They might intervene based on this decision, or no intervention if it's determined to not be necessary. They then evaluate, and then the whole process starts over again. They have to go back in to that understanding of patient status again, because patients change all the time in acute care settings. Their status is not constant. So in thinking about COVID, I'm currently doing a study on nurse decision-making and COVID in acute care settings. And so I have a little bit to discuss about. It's an early data analysis right now, still collecting data and some early data analysis. What we know is this is a very novel healthcare situation. Nurses are describing, this is pneumonia, which they've taken care of a lot of patients with pneumonia before, but it's different. So they are struggling, very experienced nurses are struggling to make decisions based on their experience because it's not the same pneumonia. So they describe patients as their decline is more rapid when they become very ill. Pneumonia patients decline sometimes, but COVID pneumonia patients can go in a matter of a few hours and become very, very ill. They also identify that there's other disease processes that occur in conjunction with COVID that haven't necessarily fallen into play with typical pneumonia. So they didn't feel that there were standards for care. On top of this is this element of fear, because there was a lot in the news, and nurses know healthcare workers were getting COVID, and they were dying from it. So they're still putting themselves in that situation, caring for those patients because they care for their patients and they want to do their best for those patients. But there is that element of fear there, understandably. So what we find early anyway is that there are new approaches to decision making and interventions, including patient advocacy, because a lot of these patients weren't able to necessarily talk with members of the healthcare team. They were limiting the number of people going into patients' rooms because the personal protective equipment was limited, and it was for safety purposes and made all kinds of sense. But a lot of times the nurse was the only one in there interacting with these patients. There is an intuitive tool that's being used by a hospital here in town that asks nurses to rank their concern for a patient on a scale of 1 to 4. It doesn't ask the nurse to describe symptoms the patients are having. It's simply asking the nurses to say on a scale of 1 to 4, with 1 being no concern and 4 being the patient is very, very, very ill, what their level of concern is for that patient. And what nurses are saying is not only does it help them kind of come to conclusions in their mind, put things together and say, all these symptoms are making me either not very concerned for a patient or very concerned for a patient. So it's helping them with their decision making, but they also describe that it's helping with communication. So they discuss their concern level for this patient with other nurses, and it provides a new way to communicate regarding patient acuity or level of illness. So this next slide is a video of a nurse who she tells she's from Harborview Hospital, and she has quite an amazing story that brings everything together, in my opinion, around a lot of these elements.
Catherine, Haley, Chris, Rebecca, Kathleen.
I can't exactly remember the exact moment I heard COVID-19. I was supposed to take a trip with my son to Japan, more and more news. It's like, we'll be fine. And then it just seemed to explode. Initially, we thought we just might need 8 beds. And then as we started getting into the COVID ICU, it became apparent that we were going to have to stretch. These patients have to come in here and they're super sick. So you have to put yourself in their shoes to feel what they feel. You're in a hospital with strangers all around you, telling you to breathe, telling you to cough, and you're restrained and tied down.
Hey Joe, this is Breezy in COVID ICU land. We're getting ready to supinate a patient and cannulate them for ECMO.
I think day 2 of me working my first week in the COVID ICU, I just knew that this was going to get a lot bigger and it could get really scary here. So I called my friend that night, and my son was on a plane by 10 a.m. the next morning. He's in Kauai right now, and he's been there since March 11th.
You already tested this thing?
Yep.
I usually work 7 nights in a row. The day before, I have to take a long nap to make sure I can mentally switch and function appropriately.
Okay.
And then you can get through your 12-hour shift. You're trying your best, all the little tricks that you've known that have worked on patients that have had the really sick lungs in the past. But these tricks are not working. People are getting sicker.
Ready?
Whenever you put a breathing tube into somebody for the first time, You risk having droplets come out. There's definitely a risk.
There you go.
You do it. Always tell them what I'm doing, even if they are sedated. I always believe that people can hear you, and you need to talk to them.
I'm going to turn you to the other side now.
I'm going to give you this med. It's for this. You just verbalize it out loud. You hold people's hands. You sit there with them, talk about something that has nothing to do with the COVID-19. You just ask them about them. So I get to know them, their families, because they can't talk to their family. You're that bridge, and all you want to do is make sure that this person can go home.
All right, arterial camp is slowly coming up.
If you're already at the max level of support that you can give and their oxygen levels are dropping, there's really not much you can do except just let the family know. And can you imagine holding up an iPad to somebody who's intubated, really sick, and hearing their family tell them goodbye? Absolutely heartbreaking.
I'm going to bring the camera over to him, okay?
Tears are coming down your face. I mean, you're human. This sucks. And we had a coworker, very young. We don't know if she got actually exposed at work, but she started feeling sick and she took herself off the schedule, doing it at home like a lot of people do who test positive. But it just came to the point where she couldn't do that.
Hey, sweetie. You're in the hospital, okay? You're at Harborview. We're going to take good care of you.
She was with us for 7 days on that breathing machine. She would write on a board. Being a nurse, she would always want to know what her vent settings were. And I think we were all standing outside the room when we knew that we were going to take that breathing tube out. And we were all so scared. We all held our breath. She had that tube out and she was fine. We finally won one. We did not let COVID win. We won. Until we get a vaccine, there is no way that this can't be part of our everyday life. We're going to adapt to it, we're going to learn from it, and we're going to grow from it. I have never been so tired when I get home. I am physically, mentally exhausted. That's when I either cry on my way home. I also take a walk down to the water when I lose patience. It's kind of a Hawaiian ritual. And just say goodbye. As a nurse, I fear getting sick, especially since now my son is not here. He texts me all the time and says, "Mom, please don't get sick." It's a possibility. This disease could take any one of us at any time, and I'd be a fool to think that I was immune. I knew what I was getting into, and I chose it. I was meant to be a nurse.
So a few thoughts around this particular presentation that address the presentation. I mean, a few thoughts around this video that are consistent with our presentation today. The amount of sacrifices that this particular nurse made, including separating from her family, so she minimized the risk for her son, for instance. She described that the previous tricks she'd been using, tricks meaning reflecting back on her experience and things that had worked with her family members, were not working any longer. When she described the droplets, she was talking about concern, human concern that she could also become sick. And then the caring piece, telling them constantly what she's doing as she's doing it so that they know that they're treated as a human, holding hands, talking to them about anything but COVID. And when she talks about being a bridge, that's a good example of the advocacy piece. She's carrying that information that makes that care patient-centered to the rest of the healthcare team. And is the conduit for that family connection when that was just something that wasn't going on very well. She talks about tears and it related to her own personal grief around patients and fear associated with this care. So advocacy in COVID associated with the study that I'm doing includes communication with the family, the healthcare team. As I was saying, a lot of these nurses were describing that they were the number of people in the healthcare team interacting with the family, with the patient, was tremendously decreased just due to the risk of others getting COVID. That family separation was an acute, terrible thing for these patients and the families. So supporting communication so that they feel less distant from one another as best as the nurses can. And then language, even if it's a Spanish-speaking person with a Spanish-speaking nurse, or an English-speaking person with an English-speaking nurse, not to mention that an English-speaking nurse who's doing her best to communicate in Spanish with a Spanish-speaking person, all of this communication was made more difficult because there was so much noise in the room and all the PPE and everything that they were wearing, but they were still working endlessly to try to be successful in that, so that these patients feel that their needs are being addressed and they understand what's going on. So as a patient, as I've said, that patient-centered care is the goal in healthcare. And how can you as a patient member feel that you are having your particular needs addressed? And this includes having that effective communication. So you are a member of that healthcare team, you're collaborating, and your needs and goals are at the center of those decisions. And this includes speaking with your nurse and expressing concerns. And it has been found to support ideal patient outcomes. When you go home, there's a lot of resources that have become more relevant in COVID, including telehealth. Interacting with people via Zoom or other methods has been something that's been a little bit of a difficult sell for a long time, but it has become much more relevant due to COVID. We want to see that healthcare records are linked between the hospital and primary care so that there isn't any missed care when somebody goes home. If a hospital physician prescribes something, we want to make sure the primary care provider knows. And that patients have the access to their charts so that you can understand what's being charted there and be able to have the opportunity to correct things as needed. So going forward in the future for research, we know that the electronic health record should be an amazing resource for decision support, but we're not effectively supporting nurse decision-making right now. There's a lot of reminders, say, make sure you check the heart rate because you're giving a medication that could drop the heart rate, but linking patient symptoms with evidence and providing some sort of recommendation as a result, that's just not happening right now. And so how can we do things better to facilitate that? So in conclusion, nurses provide essential care through their demonstration of caring and this, understanding the patient status and providing that holistic care. And it's an ongoing process. It's cyclic and takes a lot of education, experience, and underneath it all, a great deal of caring. So thank you. That's it for my presentation. Does anyone have any questions?
Okay, we'll take questions in the chat, and you can probably stop sharing the screen, Christine, which would help us.
Okay.
And again, if you can use the chat to submit a question. But while people are thinking, Christina, very, very poignant presentation and very touching video, the story that was contained in the video. Is there any data on the influence of the length of shifts or the number of consecutive workdays on decision making?
I know that there is. I am not up to date on that data, unfortunately. I know that there is. Certainly being exhausted and tired, there's data on that. I'm just not up to date on that research.
Okay, thank you. questions come in. Can you share how simulation contributes to enhanced nurse decision-making for new nurses?
That's a really good question. So when I think about experience and that whole pattern matching phenomenon, I think about nurses as having files in their head. And they do that pattern matching based on these files that they have in their head in their previous experience. So simulation can facilitate development of those files in the head that helps them to make good decisions and have something to reflect on, even if they haven't actually developed that experience based on patient care.
Okay. The next question is, have you or we changed nursing training processes at SDSU to better prepare the next generations of nurses for future pandemics?
So that's a really good question. And I would say that's still in process. This research study, for instance, will help identify what nurses' needs are and can help guide potentially, my goal would be helping to guide development of resources within the electronic health record, and then making sure that nurses graduating can use those resources effectively, because technology can be a heavy lift.
Okay. Pam Jackson would like to make a comment. Pam, if you unmute, we can probably hear you. I don't know if Natasha can do that. Okay, while we're trying to figure that out. Christina, a very good question. How important is empathy to these situations?
So empathy, I feel, is what I'm trying to convey when I say caring. So nurses they're not feeling with the patient, but they are recognizing that what the patient is going through is very important and relevant, and regardless of the fact of whether or not the nurses actually experienced it themselves, they understand that it's an important phenomenon and they need to carry that forward so that the rest of the team knows, and it's part of that advocacy piece.
Okay, good. There's lots of good questions. How do you feel undergraduate nurse educators can impact or promote early decision making?
That's a good question. I really think there's a lot that's being done right in undergraduate education. I think that the simulation piece and practicing, one of the things I was doing in simulation toward the end of the time that I was working as a nurse educator before I went into my PhD program, a lot of the preceptors were talking about the fact that nurses get experience doing hands-on skills, they get experience seeing a lot of things, but because it's a very critical environment, we can't just let nursing students go in an acute care setting. We have to monitor them. So nurses never really learn how to make decisions for more than one patient at a time. When they graduate, they're going to have 4. Now, this is my experience as an educator. So I developed patient care simulations that were not necessarily really sick patients, but patients that all had different problems and all had different communication needs and education needs and physical needs, and required that nurse to spread attention to a lot of different areas, which I felt in my area anyway, when I was educating, wasn't being addressed even in the clinical environment as well as it could be. That's my personal opinion.
Good, thank you. I think Pam's able to make her comment now. So go ahead, Pam.
Yes, thank you. First, I'm a graduate of San Diego State many years ago, but I would like to comment on nurse experience that I have had here in Payson, Arizona. In March of 2019, I was diagnosed with breast cancer at 78 years of age, and I spent a year having infusion therapy here at the Banner Hospital. I cannot say enough good words about the 4 nurses that provided my therapies to me. They worked together as a team, they communicated, they were understanding, professional, and yet we had a few tears and a few laughs along our journey. They have to know awful lot about chemo because everybody's treatments these days are customized. And everybody is there in different stages and with different backgrounds and different feelings and emotions. And they're carried me through a very difficult time in my life. And I just frankly, again, cannot say enough good words about these nurses and their professionalism. Thank you.
Thank you for sharing that. I'm really glad to hear that was your experience.
Me too.
Pam, Christine, another question that you can address. Can you describe decision-making in the context of care, for example, interprofessional practices, working with other disciplines?
So I guess could I have some more specifics on that? So interprofessional care, as I described, each patient is going to have different needs. There are certain patients that, for instance, might need particular equipment when they go home. And so making sure that communication is successful and that the people that will be overseeing their discharge home are aware of what that patient's particular needs are and potentially what their psychosocial needs are once they get home, what kind of support that patient feels that they need. Does that address your question? Or
that was from Frances. She can chime in if she'd like.
Oh, thank you so much, Christine. I love this work. I was interested in the ways in which nurses work. You mentioned in the beginning, work with others in ways in which that support best practices for patients, kind of like with their role specific and then role overlap and role uniqueness, because I think nurses are primary to the care. So I was just curious what you thought about that.
So role overlap with other healthcare team members? Is that what you're talking about?
And in the context of acute care setting and in COVID, during COVID specifically.
Okay.
Yeah.
Okay. So I think I get what you're getting at. So for instance, role overlap, my perception of your question is there were times that I heard about, and so I'm doing a qualitative study. And so I'm interviewing nurses, and nurses were describing situations where the physician didn't have access to personal protective equipment that the nurses did. So the nurses were actually taking on a lot of the roles that physicians typically took in terms of, the physician wasn't necessarily able to assess things like they had been in the past. And they were relying on nurses to provide that information so they could make good decisions and write the right prescriptions for a patient and get the best outcomes for that patient. That's one type of role overlap. They were also, respiratory therapists weren't necessarily able to go into the rooms either. So nurses were taking on those roles. Nurses were describing cleaning the rooms. Housekeeping wasn't able to go in there. So they were taking on a lot of extra roles in the face of COVID, just due to the particular factors associated with that disease. Does that answer your question? Thank you.
Probably have time for one more question if someone has one that they haven't asked yet. Okay, great. Thank you so much, Christine, for this insightful presentation. If I were to share how nurses helped me and my wife, I'll get all choked up, so I won't go there. But everything you've talked about hit home to me. And all I can say is that, the doctor would come by once a day, but the nurses were there minute after minute after minute, 24/7. And they were the primary care in that setting. They were awesome. And many of them were SDSU alums, so that was even better to experience that.
I'm glad you and your wife had good care during that experience.
We did. Well, thanks to our audience for joining us today also. We look forward to seeing you at the 5th and final event in our spring conversation series. We'll be switching over to social work. The title is Business Not as Usual: Why Using For-Profit Strategies to Run Nonprofits Does Not Achieve the Greatest Impact. That event will feature Dr. Lauren Wilner from our School of Social Work, be held on Wednesday, June 2nd at noon. And a link to the event has been posted in the chat. You can see it there. So enjoy a terrific day today, everyone. It's Nurses Week, so this was an awesome time for us to talk about nurses and the impact they make in the lives of not only patients, but like I said, all their family, friends, and caregivers. So thank you again, Christine, and thank you to our audience. Take care, everyone.
Thank you. Goodbye.